Hello everyone. Today we're going to talk about systematic review in public health. This is chapter 4 of our textbook. So systematic reviews are one of the most powerful tools that we have for making sense of scientific evidence. Instead of reading one study at a time and try to piece together conclusion, systematic review pulls everything together using rigorous and transparent method. So they reduce bias, increase precision, and help policymakers and practitioners make informed decisions. By the end of this lecture, you will understand what systematic reviews are and how they differ from the traditional narrative reviews and how they have changed the public health practice with real example you can use in your own work. So what exactly is a systematic review? So the formal definition is it is an application of strategies that limit bias in the assembly and critical appraisal and the census of all relevant study on a specific topic. Let me break that down. First, we have to find all the relevant study, not just ones you like, not just the ones that published in English, and not the ones that with positive results. Second, you have to critically appraise them. Figure out which studies are trustworthy and which one have flaws. Third, you have to synthesize the findings. Pull them together to answer the specific question. And you do all of those with explicit and transparent method so the other researchers could replicate your process. Let me give you an example. In the 1990s, where there were a huge debate about BCG vaccine for tuberculosis, some trials show 80% protection, and others show zero protections. How could that be? A systematic review by Codis and colleagues in 1994 put 13 trials over 300,000 participants. They found that overall, BCG reduced TB risk by about 50%. But they also found that effectiveness varies by latitude. BCG worked better in temperature climate like Europe and North America than in a tropical climate. This resolved the contradiction. The variation was real, not random. This systematic review guided WHO recommendations to use BCG in high-burden settings and to focus on other prevention strategies where BCG worked poorly. Now let's compare narrative reviews and systematic reviews. Most of you have read narrative reviews. They're the classic what we know about X articles. They're great for getting background information. A good narrative review can give you a panoramic view of a topic and introduce key concepts and theories. But narrative reviews have drawbacks. They can suffer from unconscious bias. The author might not be aware of relevant new information. Or worse, conscious bias. The author might be advancing a certain agenda, and the reader often can't tell which is which. Here is a classic example from 1992. Ammon and colleagues look at thrombolytic drug for heart attack, drug like TPA that break up blood clots. They compare narrative review published in major textbooks and journals to systematic reviews and meta-analyses. What did they find? Even after a large randomized trial showed that clear mortality reduction, about 20 to 30% fewer deaths. Many narrative reviews continue to recommend against these drugs. They were behind the evidence. Had clinicians relied on those narrative reviews, thousands of lives would have been lost. This study was a wake-up call. It helped accelerate the adoption of evidence-based medicine, where systematic review becomes the gold standard for summarizing evidence. Meta-analysis is a special type of systematic review. Instead of just summarizing findings quantitatively, meta-analysis use statistical method to combine data from multiple studies into a single summary estimate. Why would you want to do that? Two reasons. First, individual studies often have lower statistical power. They can't detect small but important effects. Combining them will increase the power. And second, when study seems to conflict, meta-analysis can resolve the apparent contradiction by showing the overall pattern. Let me give you a massive example. The cholesterol treatment trialist collaboration in 2010 pulled individual patient data from 26 randomized trials involving over 170,000 participants. That is not just combining summary statistics. They got raw data from each trial and reanalyzed them together. The meta-analysis showed that each 1 mmol per liter reduction in LDL cholesterol reduced major cardiovascular events, heart attack and stroke by about 20%. And this effect was consistent across age, sex, and baseline cholesterol level. No single trial have enough power to show this definitively for all subgroups, but the meta-analysis did. This single study became the cornerstone for cardiovascular prevention guidelines worldwide. It is why we put millions of people on statin today. The systematic review process has several key steps. First, you convene a team. You need a context expert to understand the disease and the interventions. You need methodologists who understand the study design and bias. You also need a librarian who knows how to search databases. You need a statistician if you're doing meta-analysis. Second, you develop a protocol, a detailed plan written in advance so that you don't change the rule after you see the result. Third, you define your research questions. Fourth, you conduct a comprehensive search. Fifth, you evaluate study quality. Sixth, you synthesize the finding. And seventh, you interpret and disseminate. Let me give you an example of a real systematic review team in action. The Cochrane Review of Hand Hygiene Intervention in Community Setting brought together epidemiologists, infectious disease specialists, behavioral scientists, and librarians. They developed a protocol that specified exactly what study will be included. Randomized trials, community settings, laboratory confirmed, or clinical respiratory infections. They search Medlines, Embase, Sino, and great literatures. Thesis conference preceding government reports, and they found over 50 studies. The review found that hand hygiene intervention reduced respiratory infections risk by about 15 to 20%. The evidence was used by WHO to update pandemic preparedness guidelines. A single systematic review done by a diverse team following a rigorous protocol changed the global policy. One of the most important steps in a systematic review is defining your research question. A poorly defined question leads to a useless review. The standard framework is called PICO: population, intervention, comparison, outcome. Population, so it is who are we studying? Intervention is what are we testing? Comparison is compared to what? Outcome is what health effect are we measuring? The textbook gives us an example. Compared to usual care, does an intervention to reduce out-of-pocket cost improve vaccination coverage among children, adolescents, and adults? That's a well-defined question. Let me give you another example from a systematic review of school-based physical activity intervention. The researchers asked, in school-age children, that is the population, does a daily physical activity program, that's the intervention, compared to standard physical education, that's the comparison, reduce obesity prevalence and improve cardiovascular fitness, those are the outcomes. That is a clear answerable question. They identified over 30 studies. They found that interventions with at least 60 minutes of daily activities reduce BMI z-score by 0.1 to 0.2 unit and improve fitness by 10 to 15%. That might not sound like a lot, but at a population level, it is meaningful. And this evidence was used by several states to mandate daily physical activities in school. Without a clear PICO question, that review would have been a mess. Searching for evidence sounds simple. Just type some words into PubMed, right? Wrong. If you only search one database, you might miss half of the relevant study. In fact, the textbook notes that computerized database sensitivity can be as low as 51%. That's like a flip a coin. And there's publication bias. Positive studies are more likely to be published, especially in high-impact English language journals. Negative or no studies often end up with file drawers. So a search that only looks at public literatures will overestimate treatment effect. Here is a famous example. Turners and colleagues in 2008 obtained both published and unpublished trials of 12 antidepressants from the FDA. They had access to everything, the study that got published and the ones that didn't. In the published literatures, 94% of trials show positive results. That sounds great. But when they include the unpublished trials, that's the one that the company didn't submit for publication or that journal rejected, only 51% were positive. That is huge difference. And a funnel plot, a graphical tool that plots effect size against sample size, showed asymmetry. A small negative study were missing from the published literature. This landmark analysis revealed the true extent of publication bias. It led to mandatory trial registration on clinicaltrial.gov. Now, if you start a clinical trial, you have to register it before you enroll the first patient. That way, we can find out about negative trials even if they never get published. When we assess study quality, we think about two kinds of validity. Internal validity is about freedom from bias. Does the study measure what it claims to measure? Randomized control trials generally have highest internal validity because randomization balances measures and unmeasured confounders. But not all the RCTs are equal. Poor concealment of allocation. If the person enrolling patients knows which treatment comes next, can bias results away from the known. The external validity about generalizability. Do the results apply the population and setting others than the ones in the study? This is often underappreciated. The RCT might have perfect internal validity, but terrible external validity if the study is highly selected patients in a specialized academic center. The classic example is hormone replacement therapy for postmenopausal women. Observational studies like the Nurse Health Study suggested that HRT reduced heart disease risk by 30 to 50%. These studies had good internal validity for what they were. Well-conducted cohort study. But then the Women's Health Initiative, a massive RCT with over 16,000 women, found that HRT actually increased cardiovascular risk. What happened? Confounding. Women who choose to take HRT were healthier overall. They exercised more, ate better, had higher socioeconomic status. The observational study couldn't fully adjust for that, so even well-designed observational study can mislead when confounding is present. That is why systematic review must be critical appraise study design and not just accept all evidence as equal. After you have found your studies and assessed their qualities, you need to emphasize the finding. The textbook mentioned evidence tables, a separate row for each study with key characteristics like sample size, design, population, interventions, and results. You also might create a forest plot, which is a graphical display where each study is aligned with effect size and the confidence interval. The overall summary estimate is often shown as a diamond at the bottom. The forest plots let you see the glance which studies contributed the most weight and whether the results are consistent. Let me give you an example. A systematic review of smoking cessation intervention during pregnancy pool 30 randomized trial. The forest plot shows each study odds ratio, the odds ratio of quitting the intervention group divided by the odds in the control group. Some individual studies had confidence interval that crossed 1. They were statistically significant on their own, but when they look at the diamonds at the bottom, the pool odds ratio was 1.44 with a 95% confidence interval from 1.28 to 1.62, clearly favoring the intervention. The forest plot made this pattern visually obvious. Policymakers could see that while no single study was definitive. The combined evidence was clear that the forest plot was presented to state legislators to help secure funding for smoking cessation program in prenatal care. The visual presentation of evidence can be important as the evidence itself. Finally, let's talk about how systematic review actually changed policy. The textbook gives us an excellent example. 0.08% blood alcohol concentration law. A systematic review found that lowering the legal BAC limit from 0.1% to 0.8% reduced the alcohol-related crash fatalities by 7%. That might not sound huge, but when you are talking about thousands of lives per year, 7% is actually a lot of lives. The U.S. Task Force on Community Prevention Services issued strong recommendations. The National Safety Council provided a summary to the Congress. The Congress provided incentives, stated that didn't pass 0.08% law risked losing federal highway construction fundings. The number of states with these laws rose from 19 to 47. That is, systematic review changed policy. Let me give you another example. A systematic review of bicycle helmet law found that mandatory helmet law reduced head injury rate by 20 to 30% among the cyclists. And importantly, there's no evidence that helmet law reduced cycling participation. People didn't stop biking just because they had to wear a helmet. This evidence was used in Canada, Australia, and several US states to pass and defend the helmet law. In Canada, the evidence was cited in legislative hearing and contributed national helmet standards. So systematic review do not just summarize the evidence and science. They save lives by guiding policies. They translate the messy, conflicting world of primary research to clear, actionable conclusion. That is why we do that.